As with all patient management, forming a good impression and determining how sick your patient may be is a crucial step. This is accomplished through a good initial assessment, where the crew should determine the patient's level of consciousness, airway and respiratory status, as well as overall perfusion status through assessment of peripheral and central pulses, as well as skin condition. A thorough and organized patient assessment is an essential part of any well-run patient encounter, and it is the foundation for good clinical care. Our evaluators are looking to understand each team's critical thinking process in forming a good list of differentials and implementing a treatment plan. Now let's talk about this year's scenario. In this scenario, our patient was working out at the gym, pumping iron, when he began to experience sudden dizziness and nausea. When asked about his HPI, or history of present illness, he reports that he has been getting over a stomach illness for the past few days and has been working out for the past 90 minutes. Dizziness and nausea is a common patient complaint, so obtaining a thorough history and performing a complete and appropriate patient assessment is critical to building a list of differentials. Placing the patient on the cardiac monitor shows a pulse of 78 normal sinus rhythm, a normal tensive BP, slightly tachypnic with a pulse ox of 94. As with any patient complaining of GI complaints and/or dizziness, a 12-lead EKG is a critical assessment tool. The initial 12-lead showed ST elevation in leads 2, leads 3, and leads AVF, with reciprocal changes in leads 1, AVL, and V1 through V3. This is indicative of an inferior ST elevation MI or STEMI. Recognizing that the patient is having an ST elevation MI, the priority of the team should be to stabilize the patient and transport the patient to a facility that can perform cardiac catheterization. But dealing with an inferior MI, there are some further considerations regarding patient treatment and possible complications. Let's look at coronary circulation and anatomy to understand why. Let's split the heart down the middle at the septum. As we noted, this patient is experiencing an inferior MI, or an MI of the bottom part of the heart. I'll color this in now. If this patient receives circulation to the inferior part of the heart through the right coronary artery, as shown here, it could also be affecting blood flow to the right ventricle. We'll discuss why this is important in a second. But how do we know if the right ventricle is involved in this MI? First, we must move lead V4 to the right side of the heart, mirroring the original position of lead V4. This lead is now known as lead V4R, or V4 right. After moving lead V4 to the right side of the chest, lead V4R shows ST elevation. This elevation in lead V4R is indicative of right ventricular involvement. Understanding the clinical significance of right ventricular involvement was a major objective of the scenario. Right ventricular dysfunction means patient's cardiac output will be dependent on preload or the incoming venous pressure to the right side of the heart. This is directly related to a patient's systemic vascular resistance, or more specifically, diastolic blood pressure. Therefore, any intervention that could possibly decrease systemic vascular resistance, such as nitroglycerin, fentanyl, morphine, could decrease preload to the patient's heart. This decrease in preload could then decrease cardiac output, or the patient's blood pressure. In this scenario, it was acceptable to administer nitro or withhold nitro due to the right-sided involvement. If nitro was administered, the patient experienced a 30-point systolic blood pressure drop, which needed to be corrected with a fluid bolus. Any patient with a right ventricular infarct could benefit from fluid administration to maintain cardiac output or address potential hypotension. It's also important to determine appropriate oxygen administration for our MI patients. Hyperoxygenation can cause vasoconstriction, which could possibly increase the ischemic area of the heart. It's good practice to maintain an oxygen pulse oximetry between 94 and 98%. As always, never withhold oxygen from a patient experiencing respiratory distress. As always, each team is assessed on affect towards the patient and other crew members, teamwork, and overall communication.